Yes, I am going to come at this from a different angle, which is really the angle of an exercise physiologist. And just to set the stage, many years ago after I completed my fellowship training in pulmonary and critical care, we developed an invasive cardiopulmonary exercise test, and I'm going to tell you a lot more about that. But it's basically a cardiopulmonary exercise test with a mouthpiece in place and a catheter in one's neck, go figure, and another one in the radial artery. And the patient is asked to pedal away for 6 or 7 minutes of incremental cycling exercise. And that testing was originally developed to detect early heart and pulmonary vascular disease. And to this day, it still does those things, and I still do those things. But along the way, about 5 or 6 years ago, maybe a little longer now, we began to recognize that not all fatigue, shortness of breath, and lightheadedness were explained by inherent disorders of the heart and the lungs and the pulmonary vasculature, and that there was something else going on. We began to look at that systematically. So that's part of the story about how I got into this business. All right, so everybody in the room knows way better than I the clinical definition or the many definitions of ME/CFS, which are continually being reworked. As a lung doctor, a lowly lung doctor, we've been using a simple Institute of Medicine version, but we fully recognize you can get a lot more granular on this. So this is what I ask my patients when I see them in our clinic. Before they go on to the exercise testing, I'm going to tell you about do you have intractable fatigue? More than 2 weeks? Yes. More than 6 months? Do you have post-exertional malaise? Which, by the way, is an incredibly, of course, debilitating and cardinal symptom of the disorder, but also fascinating to the exercise physiologist. How is it that you can overdo on one day and pay the price a day or two later? And maybe we have the beginnings of some rumblings of understanding about that. Orthostatic intolerance, we ask about brain fog, we ask about in non-restorative sleep. So that's sort of my dumbed-down definition, and what I'd now like to do is to introduce you to the invasive cardiopulmonary exercise test. So this is an individual. He's typical of many of our patients, almost all of them. They have unexplained exertional intolerance or underexplained, meaning they've been to the cardiologist or the neurologist or the rheumatologist, primary care, and whatever data exists, they don't fully explain why the patient has exercise intolerance. So they're the appropriate candidates for this test. We do approximately 10 of them a week at the Brigham and Women's Hospital. And we get some answers, and I'll show you how we go about getting some answers. We measure, and many of you may know, the non-invasive variety with a metabolic cart. Here's a pneumotachograph that measures minute ventilation at the mouth and pulmonary gas exchange, and a cardinal number, one of several, that we get out of that is an index of how impaired the patient is. And you can put a number on that in terms of aerobic capacity. It's the VO2 max, and we express that as a percent of predicted. And we know what any individual in this room should be based on large normative population studies, and the independent variables are your age, your gender, and an estimate of your lean muscle mass derived from your height. So we know what it should be, and we know what the patient achieves at the end of an incremental cycling protocol. Ergo, we know how impaired they are aerobically. Now, the important variables that we additionally measure with the help of these two catheters, the radial artery catheter and this pulmonary artery catheter, which is inserted around the corner in our cardiac cath lab through the internal jugular vein, are more indices, but in this case of systemic oxygen transport and exchange. This is the arterial oxygen content being sampled every minute during incremental cycling. And then we also measure at the distal tip of this pulmonary artery catheter the mixed venous oxygen content. And there are other things, other nuances, but these are some of the cardinal things. And you'll see that the difference between these two things is an important index of systemic oxygen extraction, the ability of the individual's muscle to take up and utilize oxygen that's been delivered to it. Another cardinal feature in ME that we have found over time, and I'll show you one published study and some non-published data, is the right atrial pressure. And it turns out that that is a real important variable for patients with ME. And I would hazard to say that almost every ME patient I've seen has low filling pressures in the upright position at the level of the right atrium. So that's a cardinal feature, and additionally, many of them have impaired systemic oxygen extraction. This I'm going to walk you through. So here's kind of our algorithm, our diagnostic algorithm for any patient with underexplained exercise intolerance, but you'll see how we come back to ME in just a minute. This is the Fick principle for those of you who have dabbled in physiology. This is the VO2, the oxygen uptake. This is the cardiac output. And as I said a second ago, this is the oxygen content in arterial blood and then in mixed venous blood. And normally, the cardiac output goes up about 5-fold above resting states, and this difference between arterial and mixed venous oxygen content widens by virtue of oxygen extraction about 3-fold, and then you realize 5 times 3 is about a 15-fold increase normally of the VO2 max in a normal or a trained individual. If you have heart disease, this number falls because of an inability to mount a cardiac output. If you have a problem in the periphery of the exercising human being or organism, you have a problem with the ability to take up and use oxygen. So that's the Fick principle, but the overall gestalt here is that if you're sick, your VO2 max is low. Now in ME, we have found 2 patterns, and they often coexist. And this one, it tends to be in more severe patients. This is a depressed peak exercise cardiac output that results in a depressed peak exercise VO2. So you can see this is down, that's down. This may or may not be normal. And that's a low flow state. And that we have found in many patients with ME, and as you'll see in a minute, we relate it to the low filling pressures at the level of the right atrium. This is the other pattern, and this is late-breaking news. We have a manuscript that's submitted on this, but these are unpublished data, and I'll show you a little bit of them in just a second. We see an inability to extract normally out in the periphery, meaning the skeletal muscle, exercising skeletal muscle, an inability to take up and utilize oxygen. That pattern has been known for many years to be consistent with mitochondrial dysfunction in the muscle. But what we also know, and this is the new news, and I hope that you'll be reading about this soon in a peer-reviewed publication, is that this is consistent with left to right shunting. This is ineffectual blood flow that is going out the aorta and getting to the level of the muscle, but it's not seeing the mitochondrion, meaning there is vascular dysregulation on the arterial side as well as the venous side that I mentioned a little bit ago. So this is how our algorithm works with these basic concepts. We identify how impaired the patient is, and then we determine whether the primary problem is low flow, low cardiac output, which sends us down this side of the diagnostic algorithm. And in ME, almost all of these patients have low flow associated with low right atrial pressures. There's nothing else, there's no intrinsic heart disease to account for it. And then the other pattern is a higher flow, a higher flow pattern. I'll come back to in a minute. So let's work on the low flow for just a second. So anecdote here, and this story will resonate, I think, really well. It will sound very familiar to all of you. So this was a patient I saw roughly 5 years ago at the Brigham. She was a chief resident in anesthesia at Children's Hospital in Boston. She's given me her permission to share the story. In fact, after the story I'm about to tell you, I pulled her back and presented her in the flesh to the cardiologists who had worked her up for what follows. So she was historically a competitive bicyclist. We heard a lot of wonderful stuff about appreciating what patients had before they got sick, and she sure was that, competitive bicyclist. And then she got the flu 2 years before seeing us, and she was not well, never got back to where she wanted to be. In fact, got worse and was unable to complete rounds due to orthostatic intolerance, dizziness, and intractable fatigue. She underwent, and we calculated, about $1 million workup, all negative, everything you can imagine, neurologic and cardiology, and to a degree pulmonary. We did a non-invasive test on her, exercise test, and her VO2 max was half normal. It should have been 150% of predicted as a competitive bicyclist. And then she ultimately went to the invasive test, and these were her data, and this is the hallmark of this disorder in our world. So she met the IOM criteria for ME/CFS with orthostatic intolerance that was prominent, and these are her right atrial pressures shown here in magenta, and they never go up. They should start at about 3 millimeters of mercury and get up to about 10. They don't even think about doing that. So she got on treatment and lived happily ever after. I got a nice email from her. She was going off to Boulder, Colorado, altitude, exercise place, to take an attending job in anesthesia with treatment. I'll come back to treatment later. All right, so we systematically, because of patients like her, investigated what other disorders aside from our usual world, heart and lung disease and pulmonary vascular disease, could be compromising patients. And this is one such published study 3 years ago, where we took, at that point, our invasive cardiopulmonary exercise database and biorepository, by the way, of over 600 patients, and essentially ruled out everything else under the sun. And then we asked, what is going on with those patients whose VO2 max is not normal, but they don't have heart, lung disease, or pulmonary vascular disease, or submaximum effort, things like that. And we compared this group of 49 patients that we found, about 8% of that population, to a group of symptomatic normals. These were 28 patients who had come in complaining of exertional intolerance, but we couldn't find anything wrong with them. Perhaps they were 60 years old instead of 20 years old. So what is responsible for this group down here? And I'll tell you at the end of all of this, most of them in retrospect had the diagnosis of ME. We didn't know it at the time. So this is how the lung doc got into this backwards. What distinguished the two groups, the normal from this impaired group that didn't have any heart or lung disease or pulmonary vascular disease, were low filling pressures, and I emphasize upright on a cycle ergometer, not supine, upright. Gravity is the enemy. And most important at peak exercise. So low filling pressures denoted the impaired group on both sides of the heart. This is the pulmonary capillary wedge pressure, which is a surrogate for the left atrial pressure. And then we attempted to ask, did that make a difference in terms of peak exercise cardiac output? And it looked like the lower your right atrial pressures were, the lower your cardiac output. These are expressed as a percent of predicted, and you can see some of these patients get down quite low. And the same on the left side, a very similar story, and the very same thing for the VO2 max. So this is a central cardiac limit that is due to preload failure. This is inability to augment normal filling pressures on both sides of the heart in the upright position that explained these patients' problems. We then took a cohort of these and tanked them up, as it were. We gave them through the central venous line normal saline boluses, and essentially you can see that with an augmentation of these filling pressures, shown over here for the right side and the left side, that stroke volume at peak exercise, they're pedaling about a half hour to 45 minutes after the first test, improves. The peak exercise cardiac output improves, as does the VO2 max. So we believe that this preload failure is a responsible pathophysiologic pathway for patients with exertional intolerance, in retrospect, most of whom had met the definition of ME. Now, these are more recent data, and this is what I alluded to earlier. This is in the form of a submitted publication. This is related, but it's on the arterial side. So this is the high flow variant of vascular dysregulation. So these are patients whose peak exercise cardiac output is above 80%, which is our lower limit of normal. And I will show you in a minute what we see uniformly when the blood flow is high. This is pulmonary blood flow that we're measuring. There's evidence that there's left to right shunting, meaning there is insufficient oxygen extraction in the periphery. So we think the preload failure is failure of venous preload and vascular dysregulation on the venous side. This appears to be a similar problem, but on the arterial side. And I'll tell you, there is a little precedent for this. This was a non-invasive study 3 or 4 years ago that looked at high flow, high cardiac output variant of POTS, postural orthostatic tachycardia syndrome. And as most of you know, I'm sure in the room, there is substantial overlap between POTS and ME. So very similar approach to this paper, but now we have we have more than 3 times the number of patients up here, about 1,500. This is up to about a year ago. We rule out everything else under the sun, and we find the patients with the low filling pressures. And I'm going to get to this in a second. We additionally required for this final N of 200 plus patients skin biopsy for something called small fiber neuropathy, which I will come back to in just a second. And here are the data, and we've expressed them in a slightly different way. We have a normal group here in gray. They have, by definition, a normal peak VO2 max, a normal peak cardiac output. They have normal systemic oxygen extraction, and these are normal filling pressures on the right side, the right atrial pressures. But what we've done is taken these other patients, all with low filling pressures, and divided them up into tertiles of cardiac output to VO2 slope. Now, I'll walk you through this because this is kind of a nuance of exercise physiology. It's been known for 30 years with an invasive testing that a normal slope of cardiac output versus VO2 during incremental cycling is about 6 ml, and that's this green group. But what we've got here are 2 extremes. We've got a low cardiac output group. That's the group we've been talking about. But additionally, and this is what we've increasingly recognized as a problem, is we've got a high cardiac output group. And remember, cardiac output in our world is pulmonary blood flow. So this is blood flow going around and around in the lungs. And then to cut to the chase here, what we've identified is the VO2 maxes in all 3 groups are in the low normal range, sort of 80 to 75% of predicted. So don't let anybody do a non-invasive test in your ME patient and say, oh, the VO2 max is 70% of predicted. That's not so bad. There can't be anything wrong, because these data suggest there can be something wrong underneath all of that. But what we see in this last group, the high cardiac output group, a lot of pulmonary blood flow, is failure of that oxygen extraction. This is the CaVO2 delta corrected for the hemoglobin. And this is the hallmark of left to right shunting. Lots of pulmonary blood flow, but ineffectual blood flow going out to the periphery and the muscle. The mitochondrion is not seeing the oxygen that's attempted to be delivered to it. So we think this is additional vascular dysregulation, but in this case on the arterial side, and surely coexists with the venous side. So read vascular dysregulation as a theme underlying the exercise intolerance of ME, I think. All right, so both things can be at play here. Now, I'm going to shift gears here a little bit. What we found ourselves asking naturally is why? What kind of pathway could underlie symptoms such as intractable fatigue, post-exertional malaise, and vascular dysregulation? And one of the answers that's evolved is this entity, small fiber neuropathy. So for those of you who don't know about small fibers, they've been kind of an underserved population of nerve fibers, not the big myelinated ones. These are the small ones. that are largely unmyelinated, very close, if not identical, to nociceptive fibers, pain fibers. But what's not been really fully appreciated is they play a huge role in vascular regulation. There's an autonomic component, both parasympathetic and sympathetic, and even in some of you, I think in the room we've talked about this, another neurally secreted vasodilatory substance that comes from these nerves called CGRP, calcitonin gene-related peptide. More on that later. Not this talk, meaning later. All right, so here are the small fibers in action, and this is how we catch them. We do it with a minimally invasive skin biopsy just above the lateral malleolus, just above the ankle. It catches the epidermis, and what you can see is in the brown, maybe not so well, are these small fibers. They run up and they innervate hair follicles, they innervate sweat glands, and importantly to us, they run along blood vessels, both arteries and veins. And even more important perhaps is that in one disorder very closely associated with a large percentage of ME patients, fibromyalgia, they run along blood vessels and potential systemic left-to-right shunts, and that's what's meant to be shown here. Here's an arteriole coming in and a venule, and here's this little bypass tract that exists in the skin. And this is a collaborator named Frank Rice from Albany Medical School in the States who's done these exquisite hypothenar biopsies of patients with fibromyalgia, and he has shown that these shunts exist in all of us, but they're inappropriately innervated with small fibers in fibromyalgia. And the importance to us is that we think they secrete this CGRP, vasodilatory substance. They can open up these shunts. And this may not be unique to the skin. This may be elsewhere in the body where we're not sampling. So we believe potentially this neurally mediated pathway, in this case in fibromyalgia, might be important in vascular regulation and maybe opening up these left to right shunts and perhaps explaining some of our exercise data. So we asked the question, what's the prevalence of small fiber neuropathy in ME/CFS, defined by my dumbed-down version of the definition? So here's our N of 223 with skin biopsies and who met the physiologic criteria for ME, and the answer is a little more than, or at about 45% of patients with either definite small fiber neuropathy. This is the neurite density in the skin biopsy. Less than 5 is a lock, and less than 15 is probable. So that's this chunk of the pie graph. I'll hasten to add that there is a more proximal version, and if you do skin biopsies, as we've done, not as systematically deeper and in the thigh, and you catch sweat glands, the prevalence rises to about 70% of ME patients with evidence of small fiber neuropathy. So we asked the next question was, does the nerve density on the skin biopsy correlate at all with the physiology that we're documenting with our invasive cardiopulmonary exercise testing? Meaning, can we marry the neuroanatomy to the vascular misbehavior during upright exercise? And the answer was a little disappointing. So it's a bunch of scattergrams. Here's the skin biopsy centile shown down here. Here would be a cluster of the abnormally low diagnostic of small fiber neuropathy. And here are the exercise variables we have over here. So VO2 max, cardiac output max, systemic oxygen extraction, and filling pressures, and there's no relationship. So that was a little disappointing to us, but we thought a little more about it. And we think that it may not be the nerve density that matters, it may be the physiology of the nerves. And you can do something called pseudomotor scans with the palm of the hand. It's electrical impedance to assess small fibers. We're embarking on that now to determine whether the nerve physiology correlates better with the vascular dysregulation that we've got. All right, so that's that. The next question is, why in ME/CFS would we have a potential small fiber neuropathy, a neuropathy? And I was at a meeting, it had to do with generic fatigue, not just ME, in Washington, D.C., and an NIH group was there, and they said, whoa, we think fatigue is caused by a particular cytokine called TRAIL. And we think it's in the CNS, and that may be. But they were unaware of the small fiber story in ME. So we asked, could we have them take a look at TRAIL? So I won't get too much into what TRAIL is, but here it is, TNF-related apoptosis-inducing ligand. It's a ubiquitous cytokine that is secreted from many cells in the body, including the muscle, interestingly. And its effect is one of two things, and I'll just, not to get too deep into this. One is to induce apoptosis. That's probably not relevant to this story. But the other is to induce the inflammasome, shown down here. So the inflammasome is induced by this particular receptor. So TRAIL secreted by a bunch of cells, I didn't say this, in response to a lot of perturbations in life, including viruses and other infections. And one of the things that it upregulates is NF-kappa B and the inflammasome, so the whole inflammatory cascade can be upregulated by this. Now, why is it of interest in something that might be a neuropathy? And that's because nerves lack a dummy receptor which tamps down the TRAIL effects, including inflammation. So nerves are particularly susceptible to TRAIL. So TRAIL can go up as a result of, for instance, a viral syndrome. TRAIL can damage nerves either in the CNS or peripherally because they lack this dummy receptor which protects them. And this group at the NIH had published a couple of studies relating fatigue to this particular pathway. Their model, though, was radiation fatigue in breast cancer survivors. And what they did was found patients post-radiation therapy with fatigue on a questionnaire, and then they looked at TRAIL levels, and the fatigued patients were way higher than non-fatigued. So we pursued with this with them in a pilot study, and we sent 41 patients with ME, high flow and low flow, and some of them with a skin biopsy, and asked what happens during exercise. And the answer is there is an exercise bump. This has not been described before. So this is super preliminary. Please take it with a grain of salt. It's preliminary, but we think potentially TRAIL would be one contributory pathway that could be neurotoxic, elicited by acute exercise. And what one might envision, and I have no proof of this part, is that TRAIL goes up with acute exercise, shown here, and then binds to receptors and goes down. This is 1 hour post, and maybe continues to have inflammatory effects. So we're wondering if post-exertional malaise potentially could be related to this pathway. Acute exercise, TRAIL up, neurotoxic, vascular dysregulation, bad day the next day. So maybe. All right, the last one I want to leave you with is a little bit on treatment, and as everybody in the room knows, there have been precious few randomized placebo-controlled studies in ME of any medical treatment. This one that I'm going to give you is not, doesn't meet all those good criteria for a clinical trial, but we have registered a clinical trial that does meet all these things, so I'll come back to that in a second. So this is mestinon, pyridostigmine. It's on the list of POTS drugs. It's been used a lot, and this was one older study that got our attention from Vanderbilt that suggested that in POTS, acute dosing of mestinon inhibits the heart rate response, and we thought maybe through improved venoconstriction. So we've been using it a lot, and this is a real self-admittedly case of the treatment getting way ahead of the science. But we've been using it in patients, and we've had some luck. I'll leave it at that so far. And we have taken a look at baseline exercise tolerance with all the numbers that I've given you so far, and identified ME patients. In this particular look at them, about 80% of these patients had bona fide ME. And we did retest with a non-invasive exercise test at a mean of about a year out. So all these patients got Mestinon, and the total dose is shown here. Someone was asking me what doses we use. So this is a pretty hefty dose, getting up there. Sort of, you may know this is a myasthenia gravis drug, off-label use for it. We think the way it works is it facilitates cholinergic transmission in the ganglion and then sympathetic outflow and facilitates vascular dysregulation. That's our guess. So these are 62 patients, 80% of whom had ME, looked at roughly a year out on a substantial dose of pyridostigmine. And we looked at them with a non-invasive test that allowed us to measure a non-invasive cardiac output and, of course, a VO2. And from that, we can calculate systemic oxygen extraction. Remember, low flow, high flow with impaired extraction. And interestingly, VO2 max did get better. Notice these are pretty good numbers, but this was highly statistically significant. Open label, not randomized. And cardiac output didn't seem to be the major thing, at least in the patients that we treated, that got better, but what seemed to get better was systemic oxygen extraction. So it's conceivable to us that nerves, we have in the aggregate neurovascular dysregulation and ME/CFS, maybe autoimmune, maybe not. And part of it may be small fiber neuropathy, autonomic variant. And when we get nerves to fire better with, as it were, with pyridostigmine, systemic O2 extraction gets better. So at least potentially the peripheral arteriolar regulation improves. So that's what I have for you today. What I wanted to leave you with was the notion that we have some pretty hard physiology. All of the ME patients essentially have low filling pressures. And that's not a number you can make up. And I should say this right now. It is not the hallmark of detraining, which I know, of course, is the Achilles heel of much of the clinical research, at least in terms of exercise tolerance. Detraining, deconditioning leads to higher filling pressures, not lower filling pressures. This is really distinct. Detraining also doesn't do this. It doesn't give you high pulmonary blood flow and evidence of left to right shunting. So I think the physiology is pretty solid. This is very different from deconditioning. And then, of course, this is way higher. Now, we haven't taken deconditioned patients who don't meet criteria for ME and done the skin biopsy on them. But Anne-Louise Oaklander, who does the analysis of our skin biopsy, has normative controls across the board. So the 45% prevalence of small fiber neuropathy is effectively versus normal controls. And then why a nerve problem in ME? Well, maybe trail. It's a potentially neurotoxic pathway with a bump during exercise. Does it poison nerves and cause this? Is there any relationship to post-exertional malaise? Don't know yet for sure. And then finally, one little treatment, glimmer of hope perhaps for a subset of patients. What we have registered on clinicaltrials.gov is a prospective double-blind placebo-controlled study of acute dosing of Mestinon, similar to the IV fluid study that we did where we will do the clinically indicated exercise test with catheters in place, document the pathophysiology, have them take placebo or pyridostigmine, have them cycle again with the existing catheters in about 45 minutes later, and see what we've got. So that's all I have for you, and thank you for your attention.